Thank you, Chairman, and our respected senior colleagues. I think this is the ideal sessions. Obviously, because of this point, we see that at least 50% of the listeners moderately obese. So I think the moderately obese is more important than over obese or under obese. And our topics is, particularly my topics is, what is the importance of this moderately or optimized moderately fatty some individuals, and what they get advantages of the obesity. Even they are obese, but what advantage they are getting? This is the basic concept of the obesity paradox. Previously, when we were students, we knows that the obesity people die earlier. Obesity people, they go to ICU very often for this heart attack. Obese patient, they goes to hemodialysis unit for the dialysis, for CKD. But this concept has been a little bit changed with the new idea of the obesity paradox. What does it mean? That means, so always obese patients should not die very earlier, and all obese patients should not go to ICU. That is, yet is there. So what is the meaning of yet? So there is construction. If we go little bit to the history of this study, this slide is basically this American Journal of Kidney, this is 2005. You see, they have shown the time-dependent association between BMI and 2 years, all-cause mortality in 54,535 hemodialysis patients. They have shown, as we show, this relative risk of CV risk, the relative risk of all-cause mortality and all-cause death, they gradually decreases. And very notice to the point, if it is audible, this is fine. So this is, you see, this point is very important. This is the crucial point. Between 30 to 35, if we BMI touches, this is very golden point. If it is, so this is the golden point. This is the point again. This is the decrease gradual point. So this is very important point. If it goes towards the more BMI, you see the all-cause mortality comes down. So this is very, very important history. It's a very long, old slide, 2005. They show there's some benefit of the obese patients if they gradually, well, they come to grow more obese than is underweight. So this again slides time-dependent association between the BMI and 2 years cardiovascular mortality in 54,535. You see this relative cause of CV death is gradually decreases as we approaches from higher obesity groups from 23 to 30, 35. So this is the basic context. The scientists try to find out what are the basic reasons of this, and this is the concept of the paradox of obesity paradox. So this again very important slides. You see the again plotted. So this is the concept again. It comes. If you see the interesting point or the cutting point of the green line and the red lines between 30 to 35 BMI index, this is a very golden important points. These have to come down with 30, 35. They get greatest advantage from this. Even they are obese, they are getting the greatest advantage. So this is very important cutting points. 30, 35, the golden points gradually comes down. You see, even they are underweight, they gradually goes down and down. Even obese patient goes out to get advantage. This is important point. Even they are obese, even they are 30, 35 BMI, that's class 1 obesities, they get advantage and they better survival, that's worse mortality. So this is the, again the very important slide that goes for these concepts of the obesity paradox. This third slide is a basically obesity paradox, is a J subset phenomena. That means if we go to the hazard ratio of 1.5 comes down, obesity goes, BMI goes up. This is the concept. This again 30, 35, this is an important point. These patients are getting better, probably better outcomes and good outcomes at this point. So this curve definitely shows the advantage of these moderately obese patients getting advantage from the underweight peoples and even obese patients as far as all-cause mortality and cardiovascular mortality is concerned. So I say in the pictorial presentation, these patients moderately obese, they're a little bit better protected from this, from the lean and thin peoples. So the points the history goes, they said, what are the definitions? Obesity paradox is medical identity, medical is the entity which hold obesity may counter individuality to be protective and associated with greater survival in certain group of peoples. The obesity paradox may simply reflect a lack of understanding of the complex pathophysiology of obesity and the association between adiposity and CVD. Is a very complex subject, abuse that my friend Shobita very clearly found. The complex presentation of adiposity is a very complex subject. Types of fat, what types of fat they are secreting and what the different functions, still we do not know. So what the pathology, so this mysterious subject is obesity is very concerned subject. So this, in a large perspective, what is the evidence of the clinical studies? You see, the studies in coronary artery disease is by Gruenberg and co-workers 10 years ago. They found in a large prospective study of involving for 250,000 patients with CVD, followed for 3 to 8 years, overweight and obese patients had lower mortality compared to the underweight and normal weight individuals. Similar findings were reported in a large cross-sectional cohort of obesity elevation and myocardial infarctions, STEMI patients in STEMI survivors. So this is again very important concept of this point. This definitely show these slides or study they show the greater survivals of the CV part is concerned than obese patients from the underweight or even moderately obese patients. So then studies in heart failure, if you find studies support these findings with all 10%, you see lower mortality rate for every 5-unit increase in the BMI. Similar results were found in younger hospitalized individuals with lower mortality in a near linear fashion as those with a higher BMI in spite of having higher prevalence of type 2 DM. So this is the very old subject, DIG trials, that digital administration group trials, DIG trial, data from the 7767 OPD patient. The DIG study definitely show the advantage of these obese patients as far as cardiovascular heart failure part is concerned. So then start with the type 2 diabetes patient even. You see the several studies have described a decreased mortality rate in obese individual with type 2 diabetes. In a pooled analysis of 5 longitudinal cohort studies, results show that the participants who were normal, it experienced higher total and non-cardiovascular mortality rate compared to those which are overweight in obese patient. So this important enlarged muscle mass and the better nutritional status comes in concept. So the obesity paradox may be partly explained by the lack of the discriminative power of the BMI to differentiate between the lean body mass and the fat mass. Higher mortality in the low BMI categories may be due to the sarcopenic obesity that is characterized by low muscle mass. So the concept is low muscle mass is more important for the BMI. So the BMI concept has been changed. It should be little bit definition to be changed. So BMI concept little will come to be lean body mass and other components should be there rather than as a whole BMI. So this body composition is more important. You say the lean body mass but not body fat were associated with favorable changes in the prognostic factors such as better hand grip strength. We can simply bedside test muscle mass by simple hand grip by the bedside. So by the bedside test, the hand grip test, you can jolly well judge what is the muscle power. Other researchers hypothesize that a decreased BMI could be a surrogate of the malnutrition inflammatory complex syndrome that may cause a worse prognosis in patients with chronic heart failure. So what is the new concept of this cachexian slow motions and malnutrition inflammatory complex syndrome, the non-nutritional inflammatory hypothesis? The undisnourished peoples more likely to develop protein energy malnutrition and slow recovered illnesses from its complications. Increased release of IL-6 and TNF-alpha may suppress appetite, may cause muscle proteolysis and hypoalbuminemia, and may be involved in the process that leads to atherosclerosis. So patients with low albumin, low cholesterol and creatinine and homocysteine concentration might represent MICS, making them prone to infection and inflammation. So this is known as cachexia in slow motions. So they simply by say this is undernourished people, why they are suffering from more heart failure than the overnourished patient. This is simply by this nutritional inflammatory hypothesis. So the TNF-alpha receptor in obesity concept. So TNF-alpha is elevated in chronic heart failure and in dialysis patient, we know that, and may contribute to cardiac injury through the pro-apoptotic and the negative inotropic effect. Adipose tissue produces soluble TNF-alpha receptors which may play a cardioprotective role. So this is known as TNF-alpha hypothesis. Then neurohormonal alterations. The lean subjects had significantly higher increase in the plasma adrenaline and renin concentration during treadmill testing despite similar baseline values and history of hypertension. So heightened sympathetic renin-angiotensin activities associated with a poor prognosis in heart failure and fluid overload states such as those seen in dialysis patients. So this is known as neurohormonal hypothesis. And endotoxins, lipoprotein hypothesis. There are so many hypotheses and reasons behind the backup of the paradox. So lower serum total cholesterols and lipoprotein concentrations are strongly and independently associated with impaired survival in dialysis patients. It reflects a richer pool of the internal lipoproteins that can actually bind to and remove the circulating endotoxins, which effectively deters inflammations and subsequent atherosclerosis. So this is known as endotoxins lipoprotein hypothesis. Then endothelial progenitor cell. This is a very new concept. Severely obese patients, despite higher levels of the C-reactive proteins and leptins, may be partially protected from the atherosclerosis through a greater mobilization of endothelial progenitor cells. A reduction of the circulating bone marrow derived endothelial progenitor cells
Durga,
has been
please conclude. Durga, please
as dropped as a novel mechanism of vascular disease. I'll take only 2 to 3 minutes. So thrombexin production hypothesis and ghrelin sensitivity hypothesis, and you see the gut microbiota comes to every part. So this is the lot of mechanisms why the obesity paradox occurs. So what manifests obesity paradox is heart failure, is a chronic heart disease, ischemic heart disease, severe stroke, peripheral vascular disease, post-operative complications following cardiac surgery, even diabetes, all are manifested obesity paradox. And investigation basically the BMI, body composition by various methods, amplitude measurement, dual energy X-ray absorptiometry, lean body mass by dual energy X-ray absorptiometry and lean body mass calculated, muscle strength by simply I have told bedside hand grip strength, and this isometric dynamometry, quadriceps strength, isokinetic dynamometry. There are so many investigations, and basically the very important is how to manage this obesity paradox people. So balanced physical exercise with weight loss is very important. Balanced physical activity, good metabolic control, the avoidance of smoking, blood sugar testing is more important than your body mass compositions, the body BMI. So periodical measurements of the muscle metabolic parameters, visceral fat by MRI or CT scan, muscle strength, etc. by proper anthropometric measurement, more important from a BMI, gradual BMI measurement. So BMI measurement, not a mere of your obesity paradox, should be measured by the anthropometric measurement, more important. Then how to conclude? Obesity is associated with a higher overall mortality risk in the general population. This goes without saying. Yet, obesity confers a survival advantage in some clinical subpopulations. Several prospective studies have reported that J-shaped curve. We have described the J-shaped relationship between the obesity and the mortality, suggesting high risks of death in lowest and the highest BMI groups. Obesity paradox may simply reflect our lack of understanding of the complex pathophysiology of obesity and associated between adiposity and CVD. Obesity paradox exists as evidence from several epidemiological and prospective. Really exists obesity paradox. Metabolic parameters and proper anthropometric measurement are more important than your BMI measurement. Obesity paradox has been reported for various diseases, including stroke, MI, heart failure, diabetic, CKD. Subpopulation of the obesity paradox. Another important point issue, this particular BMI is 30 to 35 kg per meter square. Elderly, it is found more in elderly populations, type 2 diabetes, CAD, and CKD patients. The adverse metabolic profile is bad adiposity, metabolic syndrome, etc. Most important, both in obesity individuals and with increased BMI, normal BMI response. So that's why the adverse metabolic profiles is a bad prognosis rather your good metabolic profile. So I just conclude with the thought that all the obese patients should not die earlier. So there is some populations, subpopulation of obese patients are only protected from our heavy rain by a good umbrella. Thank you very much for your kind attention.
Thank you, DP Chakraborty, for your excellent deliberation. Now I invite